Hey everyone, welcome back to our channel. Today we're diving into an important topic for those dealing with heart failure and atrioventricular AV block. We're discussing the benefits of biventricular pacing over right ventricular pacing. For patients with high-grade AV block and mild to moderate heart failure, biventricular pacing leads to a 10% absolute reduction in death, urgent heart failure care, and adverse left ventricular LV remodeling compared to right ventricular pacing. For those with high-grade sinoatrial SA or atrioventricular AV node dysfunction, cardiac pacing is essential. However, recent randomized controlled trials, RCTs, like MOST, DAVID, and the 2009 study by Yu et al., have shown that right ventricular RV pacing can negatively impact heart function in patients with heart failure and AV block. This is a crucial consideration for treatment plans. Conventional right ventricular apical pacing can worsen left ventricular function due to non-physiological myocardial activation, leading to ventricular dyssynchrony. This dyssynchrony causes maladaptive remodeling of the left ventricle, impairing its contractility. The negative impact of RV pacing on heart function highlights the need for alternative pacing strategies to improve patient outcomes. By pacing both ventricles synchronously, cardiac resynchronization therapy, CRT, can reduce ventricular dyssynchrony and improve clinical outcomes. However, CRT is more complex, costly, and has a higher complication rate compared to RV pacing. Despite these challenges, the benefits of CRT in reducing heart failure hospitalizations and adverse LV remodeling make it a valuable option for many patients. According to the 2012 ACC/AHA/HRS guidelines, CRT is recommended for patients with left ventricular ejection fraction, LVEF, of 35% or less, left bundle branch block, LBBB, with QRS duration of 150 milliseconds or more, and New York Heart Association, NYHA, Class 2I4 symptoms. Recent studies have clarified its role in reducing chronic heart failure progression in patients with a high pacing burden. Published in 2013, the BLOCK-HF trial compared biventricular pacing to right ventricular pacing in patients with high-grade AV block, LVEF of 50% or less, and NYHA Class 1-3 symptoms. Cardiac resynchronization therapy showed a 10% absolute reduction in the composite outcome of death, urgent heart failure care, and adverse LV remodeling. This was mainly due to fewer heart failure hospitalizations and less LV remodeling. The BLOCK-HF trial was a prospective, multi-center, double-blind, randomized, controlled trial. It included 691 patients split into biventricular, 349, and right ventricular, 342 pacing groups, conducted across 58 centers in the USA and 2 in Canada. The enrollment period was from 2003 to 2011, with an average follow-up of 37 months. The primary outcome was a composite of death, urgent heart failure care, and a greater than 15% increase in left ventricular end-systolic volume index, LVESV. Biventricular pacing showed a hazard ratio of 0.74 for the composite outcome of death, urgent heart failure care, and LV remodeling. Secondary outcomes included significant reductions in death or urgent care visits, death or hospitalization for heart failure, and hospitalization for heart failure. 14% of patients experienced serious adverse events related to the procedure or CRT system, but complications were relatively low. Critics noted a high crossover rate and missing echocardiographic data, which could affect the results. However, the overall benefits of CRT were still clear. For those interested in more in-depth information, check out the references mentioned earlier. Thanks for watching. If you found this video helpful, don't forget to like, subscribe, and hit the bell icon for more updates. See you next time.